I want to thank Chris and Dean too for inviting me to prepare this presentation, because I, like every sceptic, had said, okay, we've seen Sorbact before, it's been around for a long time. But when I actually started to get into the evidence, I was quite surprised by how much was actually there in terms of supporting this particular claims of this product. And so it really is a pleasure for me to present some of this material for your interest, really. Okay, as Jan said, the sort of title is this notion of antimicrobial and microbiological management, recent evidence and clinical-based strategies for stopping it, basically. Of course, I need to declare my interests. I'm paid absolute millions by all companies. I only ever present their opinion of these sorts of things. Of course not. Whatever I present is my own work, of course, and based on my own opinion and my own research. And we all know that the healing of a wound really follows a trajectory, and we know from research, principally with acute animal studies, mainly mini pigs, that there is a phase to that healing cycle, and that we should see some changes over time. Of course, we know that there's a major cellular component to having those changes take place, and so this is really the team that we're managing when we start talking about wound bed preparation in terms of healing them. But we actually recognise them by looking at these particular manifestations and seeing changes within the wound that go from that very early inflammatory response through, of course, to the epithelial cover and the healing of the wound. And I'm constantly surprised by how often I'm asked to review wounds, and people can tell me what's in the base of the wound, but can't tell me whether we should be expecting at that time. And we shouldn't have necrotic tissue 3 years down the track. It's sort of not normal. Right. The migration of the epithelium is what I tend to look at fairly closely, and we know that from this stained diagram there's an area where the epithelial cells are proliferated or replicated, and there's an area where they then migrate across the granular bed. And in most instances where all things are going well, we see these small beachheads around here, and we can see that as they migrate across, they remain healthy, and we end up eventually healing the wound up. However, there are times when we're not making these cells at all, so we don't see any beachheads or replication. And I always then think, well, there's something wrong with the patient. Is it autoimmune disease? Is it their diabetes? Do they have some psychological problem going on in their life that's leading to them not to be producing these epithelial cells? Or is it they don't like me? Now, I run through the. However, if I see these cells being reproduced, but then as they migrate across the granular tissue, they die, I'm fairly convinced then that I have a wound bed problem rather than a patient problem, and I need to start taking attention to that. So these sorts of images that we're all very familiar with, where you start to see a death of migrating epithelial cells, that tell you that something's not there. Of course, the big question then is, why is it so? Why do we see that happening? Well, there's a myriad of reasons why, as I said, ranging from the research on psychological status and the effect on this, through to nutrition, underlying disease manifestations and management, right the way through. But of course, the predominating theory is that there's probably some sort of bacterial involvement or burden when you see this sort of thing happening within the wound bed itself. That burden not necessarily is a full-blown infection. We know there is a continuum of infection right the way through, from contamination through to something where we see manifestations indicating septicemia or septic involvement of the infection. But the areas that cause the most angst, if you like, are these ones that sit here in the middle, of course, and really aren't full-blown infections, but we don't have a healing wound either. This occurs principally because of quorum sensing, or optimization of bacteria, and bacteria will actually send out chemical signals to each other. Okay, they're called auto-inducers, and we think Facebook is new. They've had it for 400 years, bacteria. Okay, they send out signals, they collect together and have parties all the time. But the other important thing about this whole quorum sensing is it's actually a hydrophobic amino acids that enable them to attach to each other and aggregate to each other. They're trying to get away from the water, if you like, that surrounds their colony. They attach together, as well as those chemical areas. Now, when they do that, they have the ability then to, of course, produce some sort of polysaccharide matrix. So here we have the rods, and here we have the polysaccharide matrix that we see that occurs. So this is the biofilm that we all talk about, and we can all experience by running our tongue around our teeth and feeling the slime, because there's a biofilm. After you cleaned your teeth this morning, you've inhaled bacteria, and they've now optimised and started to produce a biofilm over your teeth. Well, I hope you cleaned your teeth this morning. Those who didn't, you have a much bigger biofilm. But it's this polysaccharide matrix that then protects the bacteria from the professional phagocytes. Okay? So the macrophages and the neutrophils that are going to go in and destroy them have a much harder life of it, and we know that we can have lots of strategies to try to break up that area. More importantly, we know that once you get that established biofilm, it's not only the biofilm, but it actually then creates a base where they can then replicate and shed further bacteria within the wound. So we have an ongoing replication of this film within our chronic and slow to heal wounds. So that won't be news to anybody in this elite group of people. So we need to just discuss them. Well, what do we do about it? What is the strategy for getting rid of these biofilms and encouraging healing? Well, it's all about wound bed hygiene. Okay, it's all about keeping the wound bed in optimal condition, and the way you do that, of course, is removal of non-viable tissue and at the same time disrupt the bacteria. Okay, create something that the bacteria don't like in terms of trying to remove or stop that cycle of optimisation and shedding. The techniques for non-viable tissue removal are many and varied. We know there's the good old conservative sharp debridement. Of course, there's irrigation and ultrasonic debridement. There's, of course, newer microfibre cloths that we now have available for that. And then there's our friends from the blue bottle larvae who can eat dead stuff for us if we keep them encapsulated and don't have free range. So there's a whole range of these things available to us to get rid of dead tissue, and we should keep doing that and keep doing it regularly. Not this one-off debridement, I've now debrided the wound. You debride the wound every time you take it down. Right. The second area then is to start to say, well, not only can I get rid of the dead tissue, but I've got to now start to disrupt the bacteria in some way, shape or form. And one method for doing that is to actually put some sort of substance in the wound that actually attaches and interferes with the function of the bacterial cells themselves, the planktonic cells. Of course, the common one that is used or talked about is this notion of silver or iron, silver ions themselves. We know on the bacteria there are these small receptor sites, okay, on the actual cell wall of the bacteria itself. And these small receptor sites then go on, of course, to create negatively charged areas where the Ag plus ions itself are readily attached to. And once attached to the bacteria, they then interfere with bacterial functions in a number of different ways. You can see them listed there in terms of just breaking down the cell wall, interfering with the synthesis of DNA and the denaturing of proteins and enzymes within the actual bacteria itself. So this is an example of something that's attaching to the bacteria and disrupting the bacterial function. Here's an example of Pseudomonas. You can see here on the second slide when it's been exposed to silver in the in vitro environment, you can see the destruction to the bacteria that we've just talked about. So it works in test tubes, okay, well, it works in vitro areas. However, the evidence for in vivo silver is quite mixed if you look at it, and even the Vulcan study was something like 6,275 patients, correct me if I'm wrong, somebody who knows it in more detail, quite clearly showed that with putting topical silver onto leg ulcers there really was no effect over large areas. So there is evidence for silver in the in vitro situation, in vivo. There is evidence, strong evidence, but there's also counter-active evidence to that. The other problems with silver, of course, is that we tend to get a bit of a discoloration from putting that into the area. Okay, and there is some discussion about are we actually absorbing the silver into serum, so are we seeing increases in serum silver? There's only one study that I know of that's been done, and that was done in neonatal intensive care units that showed, yes, there was an increase in serum silver when you applied a silver, topical silver to that group. But I haven't seen any other studies, and it's probably something we should be looking at. Other examples of antimicrobials, of course, are iodine. Iodine, we know, can disrupt thyroid function for some patients. It is, there is a maximum dose and a time for iodine, so it's not something you can apply liberally and apply with the unexperienced hands. So it's not something you can let PCAs loose with. And there is a potential allergic reaction that can be triggered by sensitisation to iodine. Mainly people are sensitive to shellfish and nuts. Honeys, we know, is another example, and the research is really focused on leptospermum honey. So this is tea tree pollen, and it's the Kiwis call the tea tree bush a manuka bush. So they have the better marketing strategy. So they're now lobbying to have only honeys coming out of New Zealand called manuka honey, and everything else has got to be called other honey like champagne and that sort of things. And almond milk and all that discussion's going on. It does actually deodorise the wound. I mean, I don't know those of you who use honey, it's actually quite pleasant when you take the wound down. It smells good, right? Can't complain about that. And there is some debriding effect from it. Chlorhexidine is the other one, and it's fairly effective and widely used in the literature, but there is some concerns that you actually see resistance to chlorhexidine at quite low concentrations of less than 4%, so quite low before you start to see some changes. The other thing about all of these antimicrobials that interfere with bacteria via disrupting their function is they tend to have a premium cost associated with them. So whilst the evidence is contradictory across both silver, honey and iodine, their cost is always high. So trying to justify the expense on a cost-effective basis to our purchasing officers and to clinicians is a much harder proposition to put. Okay, the second option really is to start to say, well, can I actually remove the bacteria within the product itself? So I'm not really actively attaching a compound to the bacteria and changing its function. I'm just trapping these little devils within a product, and if I change the thing regularly, I'm probably removing large amounts of bacterial colonies. The benefit of this is that these products tend not to have any chemical or pharmacologically active substances within them. So that risks of the stuff we talked about with iodine and with silver in there is not there when you start using products that are purely about entrapment rather than change to function. The other nice thing about these entrapment type products is that they tend to have a lot cheaper item cost. So they're not something to make the purchasing officer twitch, which is very disappointing. Okay. How do we ensure that the bacteria is then attracted within the product? Well, there is this notion of secondary entrapment. So it's like this little snare. You have to rely on the rabbit to put his foot in that for you, right? And it's the same with some of the hydrofiber dressings. You rely on the bacteria to be trapped. And there will always be some bacteria trapped because it's in solution within the structure of the product itself, okay? But there's no actual attractant, if you like, to bring the bacteria within there. It's more the physical entrapment. The other option is to actually look at more of a bonding process where you create something within the dressing that then bonds with the bacteria so that it's got no other option but to stay within the dressing and be removed with the dressing. So in the case of the product we're talking about tonight, Sorbact, it actually claims to have this ability to bond bacteria within its structure, and it relies on a fatty acid derivative coating. Okay, you can see it listed there. I'm not going to even attempt to say its name, but DACC is how it's shortened to. And this fatty acid derivative is the same fatty acid that you see on spider webs, which enable spider webs themselves to actually resist fluid on the actual web itself. So it's hydrophobic, if you like, to fluid. So it keeps water off of the web so the web is still sticky and can trap insects. What do we mean by hydrophobic mechanisms? Well, again, a lot of people sort of struggle with exactly what this is, but if you think about putting oil in water, if a molecule is hydrophobic, it doesn't like water. So if you place it in an aqueous environment, it will seek to remove itself from that and attach itself to something that is also hydrophobic. So if we do it with oil, you see we put oil in water, initially you see this mix, but over time the oil itself will then actually collect together, because the hydrophobic nature of this mechanism is that the hydrophobic molecules collect together away from the actual water itself. You can see there in the base. So that's what we mean by hydrophobic action. Okay, so in the bacteria side, it might be interesting to know that most of the pathogens that cause trouble in our wounds are actually hydrophobic, okay, by nature. So if you take your bacteria, place it into a wound environment, an aqueous wound environment, then it will seek out other hydrophobic molecules to bond with. And the DACC that we talked about before is also hydrophobic. So what happens is But that coating of DAC then bonds with the bacteria and it holds the bacteria within the product itself. And this image talks, is an artist's interpretation of what that actually looks like. So it's the hydrofibers will trap, but this ensures that you get the bonding of the bacteria and the removal with the product itself. Once bound to the DACC, there is, as I said, some evidence that the bacteria exhibit a decreased rate of replication. They are slower to metabolise and they have a decreased production of bacterial toxins. So not only are you bonding them to the product, you're also reducing their function in terms of their harmful effects on the wound itself. The potential benefits of this is you don't actually start to get a bacterial resistance. So whilst we haven't clear evidence that silvers are generating bacterial resistance, there is a thought that it will happen. Okay, it's the Pantene approach. It won't happen overnight, but it will happen at some stage. There's no saturation of dressing. Okay, there's no selective binding. It will actually take all bacteria and bind within the product, and there's no systemic absorption or side effects of the product itself, like we've said before. So this mode of action seems at least plausible and simple and relatively inexpensive. We've got to say what evidence has been actually presented around this in terms of wound-related research that shows that this particular mechanism is beneficial to the healing of wounds and the reducing of bacterial counts. Well, I've undertaken a literature review, and I'm just going to run through some of the key examples and the better studies that talk to that particular question. So here was a study done by Totti. You can see the actual reference at the top there, where they actually looked at coating a DACC-coated dressing in the management and prevention of wound infections and undertaking a systematic review. So this is a review of all studies, if you like, that have been done. You can see it was published in 2017. They concluded that there was at least some evidence throughout the majority of the studies they looked at that suggested that this product was at least reducing bacterial burden within wounds itself. And I recommend anybody wanting to look further into this to start with that review, because there's just quite a nice summary of the different reviews. This study is cited in that review, and you can see it's by Gentili in 2012. And what they did was to take 19 patients that were chronically infected, that had chronically infected ulcers, and they treated them for 4 weeks with Sorbact, which they changed twice a week. So just twice weekly change. Clinically, they had 7 healed. It improved in 9 people and 4 showed no further response. And microbiologically, which is the important thing, 66% showed reductions in bacterial load. So whilst this isn't a randomised controlled trial, it's a case series, the reduction in bacteria, the trend of reduction in bacteria is quite compelling in terms of just looking at this small study. A much larger study you can see by Mosti, okay, where you can see it listed there in the Journal of Wound Care back in 2015. And what they did was to actually undertake a pilot RCT with 40 participants. They did microbiological swabs on day 0 and day 4. And on day 4 there was an average bacterial load reduction of about 73% with the Sorbact product as compared to 41.6% with with the normal silver dressing product. So both have reduced bacteria, but the amount of bacterial reduction you can see is much more significant, down to 0.001 for the group that had the DACC dressing. This study by Clintels in 2015, also from South Africa, was a cohort study, and what they did was look at full thickness burns. So this is away from the chronic wounds now, this is more the acute wounds. So these are partial and full thickness burns in 13 patients. Sorbact versus 2 brands of other silver dressings were used. So this wasn't a randomisation, it was a case series, as I've said. They had wounds that were large enough that 2 or 3 dressing types could be applied. So they were using the wound as the control rather than randomly assigning patients to a control or an experimental group. And I wish we could do a lot more of this research in wound care, but often ethics committees prevent us from trying to have 2 or 3 dressings within one wound for very sound ethical reasons, and that is that we should be doing it on animals, not people. So I'm not quite sure how they got past this one, but the important thing about this study you can see is that DACC quite clearly reduced had a much cleaner wound, 58%, with significant positive bacterial culture of only 33% versus larger amounts in the other two groups with silver. So again, all are reducing bacteria, but the amount of bacteria reduction is much higher with the DACC product. This study in 2008 had 116 patients, multi-centre review. So this one again was quite a mix. So the last lot were chronic, and then we had burns. Now we've got chronic and burns in the same study, and ulceration. 84% of them were infected on the initial assessment. They treated from an average of 37 days, changing twice a week. 72% wound healing improvement, 21% healed for the other group, and 81% of the infected wounds were no longer infected. So again, that trend of reducing bacterial counts seems to continue through the literature. There is also within the evidence a number of case presentations, so these are a lot less rigorous studies, but they again show the same trend that I've just explained. So here's 8 case series, up to 21 wounds if you add them all together. There was a variety of wounds in 4 of them, abdominal wounds in 1, diabetic foot ulcers for 3, treated with Sorbact dressing. Assessment size, slough and those sorts of things we normally review were evaluated, and the rate of healing. All reported healing or improved appearances with reduced signs of infections or inflammation. So whilst this is quite low level evidence, the trend still remains that we see an improvement in the wound. There's also some question about it. This is good for acute wounds and good for chronic wounds, but is there also an indication for this to be used prophylactically? And there's some recent studies that suggest that probably is the case. This one done in 2016, or published in 2016 by Stranowoski, where they actually looked at a randomised controlled trial evaluating the DACC product in impregnated dressings on surgical site infections in women with principally caesarean section wounds. The findings for that, it was a single-centred, single-blinded randomised controlled trial. So it blinded to whether in fact they were having Sorbact or not. Sorbact surgical dressings and simple surgical dressings were used. 543 patients underwent the caesarean section. So this is a study we can have more confidence in. We've got randomisation, we've got blinding, and we've got a large number of patients. So our confidence levels gets much higher when we start to see these things being produced. And they evaluated the presence of surgical site infections using the CDC criteria during the first 14 days after the caesarean section. The findings again show that trend that we've talked about. Okay, 5 surgical site infections in 277 cases that had the Sorbact versus 14 surgical site infections in 271 caesarean sections that were the control. So it's 1.8 versus 5.2. And it was statistically significant down to 0.004. It was also clinically significant with a 65% relative risk reduction using the normal risk reduction analysis for this client group. So whilst 5 versus 14 may not seem like a lot, just saving 1 or 2 surgical site infections is a substantial saving to the institution and, more importantly, a substantial improvement in the quality of life that the patient experiences during their health journey, particularly as a caesarean section where they try and look after a new baby and all the things that go with that. This one, recently published in 2017, was a pilot study where they looked at using the DCC dressing the prevention of surgical site infections following non-implant vascular surgery. So the last one was caesarean section. This is non-implant vascular surgery. Okay, and you can see here again 200 non-implant vascular surgery patients were recruited, 100 into the standard treatment and 100 with the DACC Sorbact coated post-operative dressing. The rate of surgical site infection at 5 days was significantly lower in the DACC group when compared to the standard dressing, down to 0.005, as you can see there. There was no difference in the rates at 30 days though. So it's quite interesting that we've seen quite a significant reduction 5 days after the surgery up to 30 days after there was no further reduction, or no significant reduction in either group. But it's that early days after you've first done the procedure where the infection's often introduced at the time of surgery that we start to have the major problems. And they did undertake logical regression in this study, which showed that the actual predominant predictor variable was the actual dressing itself, so it wasn't something else that was leading to these lower surgical site infections, and you can see the stats there that supported that assertion. The team also presented that they actually are currently undertaking quite a large multi-site study in Europe underway, and they presented the preliminary findings at UMA, and the similar trends were there in the larger study. So we need to see that published, of course, and to find more information. But interesting evidence that seems to keep pushing to this notion, this trend, that by using this particular product and binding the bacteria using a hydrophobic action is enough to actually help reduce the bacterial burden within the wound. So in summary, because I know you're hanging out for your dinner, it's really all about the wound hygiene, right? When it comes to removal of necrotic tissue and when it comes to the bacterial disruption options, we need to be selecting products that have an evidence base to them. So do we have the evidence around some of the other interventions I've talked about? There's a cost effectiveness to them. Okay, so is the product actually fairly cost effective? And what's the potential impact on the wound and the patient and the context? Am I dumping sterling silver into the environment where I don't need to be doing it, when I could be using it for jewellery that I can sell down the market and that sort of thing? So, all important questions to look at, and I've really just presented my interpretations of the findings around this particular product. So with that, I'll just say thank you very much, because I am conscious there will be areas later on today.